educator, and today's topic is shoulder joint and all the other upper limb joints, and we'll be covering everything in brief, but we'll be going in detail with shoulder joint. All right. Yes, and this is topic number 5 in our upper limb revision series, and we have already covered plenty of topics in the previous classes, and if you haven't seen them, please go back and revise it and then come back to this topic so that you will understand this better. Then the core features of Auricle is we have live classes, recorded sessions, notes, and MCQs. In the live classes, you will get educator who is teaching you live, and you can clarify your doubts with the educator then and there, and it will also help you to keep on track. And in the recorded sessions, if you haven't understood anything, you have some doubt, or you want to know more about a topic, you can always go back to the recorded sessions. And we also have crisp notes, which are according to the recent CBME curriculum, and MCQs, which will help you in your upcoming next examination. And all of these combined together will definitely help you to ace your prof examination. And the personalized counseling session is something that you should definitely avail, because here you will be given a buddy, here you will be given a mentor who will help you with everything, academic and non-academic. They'll analyze your weakness, they'll analyze your strengths, and they'll also give you a study plan as to how to go about your prof examinations. And even if you're not, you just want to share anything which is not academic, you're getting stressed out, you're being overwhelmed with examinations, you can actually share anything and everything with the mentor that will be given to you, and which I think is a very good thing for first prof students. And we have 3 different plans: basic, standard, and premium. In basic plan, you will get pre-recorded sessions, live classes, and just quick revision examination modules. Whereas in the standard plan, you will also get live doubt clarification, right? And in the premium plan, you will get pre-recorded sessions, live class, doubt clarification, and more importantly, one-on-one personalized guidance sessions. And of course, you'll get the notes and quick revision examination modules as well. You can use my code Dr.Sushma 20 for additional discount on all the subscription and all of these plans. Yes. So with that introduction, and this is the tentative timetable. In revision 1 class, we'll be covering all the other important topics, something that I feel is important for your prof examinations, like axilla and pectoral girdle and mammary glands. And revision 2 class is going to be completely exam oriented, right? I'll tell you how to approach questions, how to approach a 10 marker, how to approach a 5 marker, how to approach a 3 marker question, and how to approach your practical examination, which is very important. And I'll also give you tips to ace in practical examination, because practical examination is all about how you present yourself. So all of these tips will be given in the revision 2 class. Yes, in today's class we will be studying about the joints of upper limb. Okay, and I'll briefly touch upon all the joints, but the main focus is shoulder joint, right? Joints of upper limb is very important for your theory, not so important from practical point of view, but for theory you will definitely get a question on shoulder joint, be it a 10-mark long essay, maybe short essay or short answer, but definitely one question will come from shoulder joint. All right, so let's look at a clinical case scenario. We have a young tennis player who presented with pain and deformity of the shoulder while practicing for Grand Slam Wimbledon. Okay, the patient has come to you with pain and deformity, and is holding the shoulder like this, and you see that patient on in your emergency room, and you order for a chest x-ray. On chest x-ray, it shows that there is anterior dislocation of shoulder. AP view x-ray shows that there is anterior dislocation of shoulder, and the question is asking which of the following statements is wrong. Which of the following statements is wrong is the question. Look at the question, right? Look at the options here. The Bankart lesion may occur as a complication, which is right. Bankart lesion is a sequelae of shoulder, recurrent shoulder joint dislocation. Second, it can also be caused by fall on outstretched hand. Of course, yes. Anterior dislocation actually happens because of a fall. And third option is radial nerve is the most commonly injured nerve, and fourth is none of the above. Guys, even if you don't know anything about the topic of shoulder dislocation, you should still be able to answer this question depending upon what we had learned in our previous classes. What did I teach you? Radial nerve injury is most common during the fracture of the shaft of humerus, not during the shoulder dislocation, isn't it? Even let us assume that you don't know anything about shoulder joint at all. Still, should you be able to answer this question, because radial nerve injury is not common in shoulder dislocation, rather it is common in shaft of humerus fracture. Okay, so the answer for this question is radial nerve injury. If radial nerve injury is not the most commonly involved injury in shoulder dislocation, then the question comes, which nerve gets injured in anterior dislocation of shoulder and how? We'll get answer to all these questions as in when we go through the topic. For now, remember, first point sorted, that radial nerve is not the most commonly injured nerve during shoulder dislocation. Yes. Now, let us start with joints of clavicle. Clavicle mainly has two joints, sternoclavicular joint and acromioclavicular joint. Sternoclavicular joint is medial because the medial aspect of clavicle joins with the sternum, and the acromioclavicular joint is the lateral one, right? Acromioclavicular joint is the lateral one. Yes. Let's look at the sternoclavicular joint first. Sternoclavicular articulation is a synovial double plane joint. Look at the words. It's a synovial double plane joint composed of two portions separated by an articular disc which is made from the fibrocartilage. Whenever you speak about joints, guys, the first point that you always should mention is what type of joint is it? Correct? What type of joint is it? The next point will be the articular surfaces. Next point is going to be the articular surfaces. Third point, what you should write in your exam is the relations. Fourth point is movements. Fifth point is clinical anatomy. So this is the order in which you have to approach a question, any question on the joints. So going by the same order, sternoclavicular joint is a type of a saddle type joint. It is a saddle type joint. Quick revision of on the types of joints. It's a homework for you guys. What is a fibrous joint? What is a hinge joint? What is a saddle joint? What is a synovial joint? You will have to tell me in the next class what are these different four types of joints along with examples. This will for sure be asked in your practical examinations. Either they'll ask you this in Viva, or they'll expect you to know this when in general anatomy. Okay, types of joint is a very important question both in theory and practical. It's a homework for you guys. Different types of joints: fibrous, saddle, hinge and synovial joint. You will tell me tomorrow with examples the definition of these joints. Now coming back to sternoclavicular joint, it's a type of saddle joint. It's a saddle type of joint which involves movement in two planes. Okay. So basically this involves movement of the clavicle predominantly in the anteroposterior and vertical planes. It does not allow it in a 3D plane, but it involves in AP as well as vertical planes. Now, second is the ligaments and relations. Any upper limb joint, any lower limb joint, if you take, you will always have certain ligaments which are present there to strengthen the joint. Why do we need to strengthen the joint? Because you basically just have two bony surfaces. There's no glue between them which can hold these two joint surfaces together. You need to have something in between them or something around them which strengthens these two articular surfaces, which is very important, right? If you do not have anything that strengthens these joints, strengthens these articular surfaces, what happens is dislocation, right? If imagine that these are the two different articular surfaces who are there, who are there in the joint, and when I do any movement, let's say I'm abducting my arm, so this joint surface is moving away. If I do not have any joints which are strengthening, any ligaments which are strengthening this joints, it easily slip away. Basically any ligaments or any bursa that you come across in any joint, it is there for the only reason to strengthen the joint and to allow the movement effortlessly. So let's look at the ligaments of the sternoclavicular joint. Number one, we have anterior and posterior sternoclavicular ligaments which are present on the anterior and posterior surface. Very easy. Interclavicular, look at this guys. This interclavicular ligament, it actually links the two ends of the clavicles and it is present on the superior surface of the manubrium sternum. And it is present on the superior surface of the manubrium sternum. Then, of course, we have the costoclavicular ligament, which is positioned sort of laterally to the joint and it links the proximal end of the clavicle to the first rib and the related costal cartilage. Costoclavicular, interclavicular, anterior and posterior sternoclavicular. The names are self-explanatory. Sternoclavicular meaning sternum to clavicle. Interclavicular meaning between two clavicles. Costoclavicular meaning costal cartilage and clavicle. As simple as it gets. Yes. Then we have acromioclavicular joint. In the acromioclavicular joint, I've already taught this in scapula, right? I've already taught this in when we were doing scapula. This joint is located at the tip of the shoulder where the acromion portion of the scapula and the clavicle join together. Simple. This has been covered already. Acromion process of scapula and the clavicle. Where do they join? Where the at the tip of the shoulder where the acromion portion of the scapula and the clavicle join together. Now, this AC joint, if you look at this AC joint, it's not very mobile. It's not as mobile as the shoulder joint. Look at the location, guys. This is where the shoulder joint is. This is where the AC joint is. Correct? This is the acromion. This is AC joint. This then a question should arise in your mind. Then why do we have this joint in the first place? Correct? We have this joint in the first place because to stabilize the shoulder joint, if I hyperabduct or adduct the arm. So basically this AC joint may not be as mobile as the shoulder joint, but it aids in shoulder is in overhead position or when the shoulder is adducted. Okay. Now this joint is partly filled with the thick part of cartilage which is known as the meniscus. Where else do we see meniscus and which else joint do you come across the word meniscus? We hear this in knee joint as well. You hear this in knee joint as well. And it's a question to you. You will have to tell me more about meniscus in the next class. Why do we have meniscus in the first place? Question mark. Second, you will tell me about the definition and the uses of meniscus. Okay? Yes. Let's go to the ligaments. Now, acromioclavicular ligament. Self-explanatory. Acromioclavicular ligament. Look at this. Basically connecting. If I have a joint, two articular surfaces like this, it is encircling the joint. Suppose if these two are the articular surfaces, it kind of encircles this joint. Correct? And also we have coracoclavicular ligament. Again, it consists of two ligaments, the conoid and the trapezoid ligaments. This is the conoid ligament and this is the trapezoid ligament. Together, we call it as the coracoclavicular ligament, which strengthens the clavicle, right? Let's say you can look at this. By looking at this diagram, you should get an idea as to why this ligament is there. Suppose if the clavicle, which is like this, held by the two ligaments, conoid and the trapezoid ligaments, which is held like this to the coracoid process, right? If the clavicle moves up or down or anterior or posterior, you can clearly see how these ligaments stabilizes the clavicle. You can clearly see how these two ligaments stabilizes the clavicle and prevents it from over motion, prevents it from moving too much and dislocating itself. Okay, so these are the two ligaments we have, acromioclavicular and coracoclavicular ligaments in the acromioclavicular joint. Next, we have the bursa of acromioclavicular joint. I've already told you whether we have ligaments, whether we have bursa, we have it for the only sole reason to allow complex movements, Now, this bursa is formed by the synovial membrane of the joint capsule, and there are number of bursae here, right? You have subacromial bursa, subscapular bursa, and subtendinous bursa, and all of these bursae are strengthened between the joint capsule and the tendon subscapularis muscle. Basically, this subscapularis muscle strengthens this bursa. It kind of goes around this and it strengthens the bursa, which is important. Ligaments and bursa are there to strengthen the joint space and also allow complex movements. Very important concept here. Then let's go to the shoulder joint. Shoulder joint is also called as glenohumeral joint. Glenohumeral joint. Sometimes they may just give this name glenohumeral joint. Make yourself familiar with this name. Shoulder joint is also called as glenohumeral joint. Guys, this is the most important aspect of today's class. First point, shoulder joint is a type of which joint? Shoulder joint is a type of which joint? I think this everybody knows, everybody should know this. Shoulder joint is a type of synovial, ball and socket type of joint. First question, opening statement. Shoulder joint, if a question is asked, the opening statement is it is a type of multi-axial, synovial, ball and socket type of joint. That's your opening statement of shoulder joint. Second point, what are the articular surfaces of the shoulder joint? Name only says there is gleno, there is humeral. Glenohumeral. We have the glenoid cavity of the scapula and the head of the humerus as the articulating surfaces of the shoulder joint. Shoulder joint, point number one, it is a type of multi-axial synovial ball and socket joint, and glenoid fossa of the scapula and the head of the humerus are the articulating surfaces. Now, this glenoid fossa that I'm talking about is a depression on the head of the scapula between the acromion and the coracoid process. You can clearly see it is a depression here. Now, one thing concept wise you have to understand, guys, the head of the humerus is much bigger than compared to the glenoidal labrum, than compared to the glenoidal fossa, because of which, because of this disproportionate articular surfaces area wise, shoulder joint is extremely prone for dislocation. Imagine, guys, this is the let us say that this my on my left hand is the glenoidal labrum and my right hand is the head of the humerus. My glenoidal labrum is only this small, but the head of the humerus is this big, right? There is a clear disproportionate in terms of area when it comes to the articulating surfaces, makes it more vulnerable to dislocation. So shoulder joint is once a joint which is extremely prone for dislocations and recurrent dislocations. Once there is some once the dislocation happens, the patient becomes more prone for recurrent dislocations. Okay, yes. Due to very limited interface between the humerus and scapula, it is the most mobile joint of the human body. There are two sides to it. One thing is, because of this disproportionality, the joint can move the way the head of the humerus can move in the way it wants, right? Because the glenoidal fossa is only this small, so the head of the humerus can move wherever it wants, meaning it is giving it more area, more surface area for the movement of the head of the humerus. Because the head of the humerus can move around, it will also give us the it will also give us the gift of mobility, isn't it? Because the head of the humerus can move around, because the joint space is so much, it gives us the gift of mobility. And be- because of this reason, shoulder joint is the most mobile joint of the human body. Because of this disproportionality, there is a gift, that is, it increases mobility. On the other hand, what happens? It makes the shoulder joint prone for dislocations. All right? Yes. Now, what is this glenoidal labrum that I'm talking about? It's nothing but a fibrocartilaginous rim that is attached around the margin of the glenoid cavity in the scapula. The fibrocartilaginous rim is what is the glenoidal labrum. This is the glenoidal fossa. And this cavity or this fibrocartilaginous rim is what I call as the glenoidal labrum. Because we have this kind of an attachment here, it deepens the articular surface, it deepens the articular cavity, and also it protects the edges of the bone. Above it continues as a tendon of long head of biceps brachii. What is this? This is the fibrocartilaginous rim or the fibrocartilaginous structure, which I call as the glenoidal labrum, that deepens the articular surface, and it continues above as the biceps brachii tendon. Yes. Now let's go to the most important ligaments of the glenohumeral joint. Ligaments of the glenohumeral joint. First ligament is the superior glenohumeral ligament. Imagine, guys, this is, let us just imagine, shoulder joint is all about your imagination. The more you imagine, the more you get oriented to the topic I'm teaching. Let us assume that this is the glenoidal labrum and this is my humerus, head of the humerus. Okay. Now, this is the glenoidal labrum, head of the humerus. Now, let us say that I am trying to abduct my arm. When I'm trying to abduct my arm, you can clearly see the movement of the head of the humerus. It is going inferiorly, it's going inferiorly. If there is nothing present here superiorly, which is holding the head of the humerus, will it not slip away? Are you trying to understand what I'm teaching? This is the articular surface, head of the humerus, and I am just trying to abduct my hand. I'm trying to abduct my hand like this. Because of this, what is happening? My arm is getting abducted. Simultaneously, the head of the humerus is going down. If I do not have anything superiorly to bring this up or to prevent this complete inferior translation, I'll have dislocation of shoulder joint. What prevents this inferior translation is the superior glenohumeral ligament. Superior glenohumeral ligament, which is very important. Okay, simple, easy to understand articular surface. As it moves, I'm trying to abduct. As it moves, it can actually slip away like this. What prevents this? SGH. Let's go to the middle glenohumeral ligament. This ligament resists the inferior translation when the arm is adducted and externally rotated. When I do this movement, okay, when I'm doing this movement and in adducted position, what prevents the movement of my inferior movement of the head of the humerus in the articular surface is the middle glenohumeral ligament. Lastly, I have the inferior glenohumeral ligament that resists the humeral head anterior and posterior translation. Same thing. The concept is the same thing, guys. I have, let's say, this is the articular surface, the glenoidal labrum, and this is the head of the humerus. When I'm doing this movement, when I'm adducting my shoulder, look at my right shoulder, right? When I'm adducting my shoulder, head of the humerus, where is it going? It is going up, goes up and up and up, and it finally can get dislocated. What prevents it? Inferior glenohumeral ligament. Understood? These three ligaments helps the head of the humerus to stay in position. Right. Next, the transverse humeral ligament strengthens the capsule and bridges the gap between the two tuberosities. This is the transverse humeral ligament, guys, which strengthens the capsule of the shoulder joint and also it bridges the gap between the two tuberosities. Now a question to you, revision question. What is there between the two tuberosities? What three muscles are there between the two tuberosities in the head of the humerus? I'll give you a hint. Lady between two majors. You will tell me in the next class what is there in the intertubercular sulcus. Okay. Question. This is homework number 3. Yes. Then I'll be giving a lot of homework questions today, and it'll be like a good revision for you guys also. Then we have the coracohumeral ligament. This coracohumeral name only says it is coming from the coracoid process of the scapula to the humerus. It strengthens the capsule above and stretches from the root of the coracoid process to the greater tuberosity of the humerus. This is the coracohumeral ligament. See how it's actually getting attached, or actually it is holding the head of the humerus properly into the glenoidal labrum. See, all of these ligaments, that whatever I have told you, whatever I have shown you until now. Look at the inferior glenohumeral ligament. Look at the coracohumeral ligament. Look at the transverse ligament, right? And then, of course, look at the superior glenohumeral ligament. All of this, middle glenohumeral ligament. These ligaments are what helping to hold the head of humerus in position. Otherwise, it will slip away. Yes. Let's go to the relations of shoulder joint. Very easy, simple to understand. Coracoacromial arch and subacromial bursa and supraspinatus and deltoid. Supraspinatus and deltoid, right? If you don't know anything in this, write deltoid, okay? Don't know anything, you have no idea about relations of shoulder joint, whether superiorly, inferiorly, anteriorly, posteriorly, just write of deltoid. Deltoid is a relation in across, right? It is superiorly related, inferiorly not so, but anteriorly, posteriorly, it is related. So if you don't know anything, write of deltoid. Inferiorly, it is related to the long head of triceps, axillary nerve, posterior circumflex humeral vessels. What did I teach you in the last previous class when I taught you about the nerves? Whenever we think of axillary nerve, which is the artery that should come to your mind? Posterior circumflex humeral vessels. Another question, quick revision. What is the space around the shoulder joint through which axillary nerve and the circumflex humeral vessels come from? Option number 1, which is upper triangular, option number 2 lower triangular, option number 3 quadrangular. Quick revision, you will tell me the answer in the next class. So inferiorly, it is related to axillary nerve and posterior circumflex humeral vessels. Anteriorly, we have subscapularis, of course, deltoid, and coracobrachialis. Posteriorly, we have infraspinatus, teres minor, and deltoid. If you don't know anything, deltoid. Inferiorly, guys, remember axillary nerve and posterior circumflex humeral vessels. Okay, relations should not be a big deal, easy to write. Yes. Then let's go to the movements that most of us get confused. Okay, most of us get confused when it comes to movements, but let's not get confused. Let's try to understand the movements in one go. Just have a look at this diagram first. Okay, this is the acromion process. This is the clavicle. This is the glenoidal labrum. You can clearly see how smaller it is as compared to the humeral head. These are the rotator cuff muscles. Homework number 4. What are rotator cuff muscles and where are they attached? 4 rotator cuff muscles and where are they attached is homework number 4. All these things have already been covered. Yes. Then we have the 2 tuberosities here. In between them also we have transverse ligament. This is the humerus and this is the scapula. Just have a orientation. This is how the shoulder joint looks like. Now let's go to the movements. First movement is flexion and extension. If I move my hand like this, it becomes flexion. If I move my hand to the back, it becomes extension. Flexion, extension. Now let us try and understand what muscles will cause this flexion and extension. You will not memorize this, you will try and understand. Okay, no point in memorizing this. Suppose if I have to move my hand like this, how is the motion possible? Either somebody has to come and push my hand like this, correct? Or something in the front should contract and pull my hand like this. This is the only 2 ways this movement can happen, isn't it? Either somebody has to come and push, which is not possible. I have to do it voluntarily. What is the other option that I have? Something in the front, some muscles in the front must contract so that they will pull the muscles forward. What muscles do we have over here? Pectoral girdle. Important muscle of the pectoral girdle, pectoralis major, and of course the anterior fibers of deltoid. Is there anything difficult here? If I have to do this flexion movement, the muscles in the pectoral girdle, the main muscle, which is the pectoralis major and the anterior fibers of deltoid, must contract so that my arm comes forward. Understood? Anything difficult here? First movement we sorted flexion. Flexion of shoulder joint is brought by the clavicular head of the pectoralis major and anterior fibers of deltoid. That's it. Simple, easy to understand, don't complicate. Next, if I have to do this extension movement, I'm actually doing, this is basically like march past, kadam tal shuru kar, that you would have done this in school, no? Ek, do, ek, same. When I push my hand backwards like this, what should happen? Somebody should give a dhakka here, which is not possible, or the muscles in the back should contract and pull the arm behind. Correct? Understood? See, then what are the muscles that are there posteriorly? One muscle is the latissimus dorsi. Name only say it is in the dorsal area, dorsum, dorsal. And second are the posterior fibers of deltoid. Is there anything to memorize here, guys? Apply logic, understand, apply logic, and write. Don't mug up, don't memorize. You will get confused in exam. Okay? Now, flexion movement is this, extension movement is this. Understood the concept, very easy, right? For flexion, we need pectoralis major, anterior fibers of deltoid. For extension, we need posterior fibers of deltoid, latissimus dorsi. That's it. Accessory muscles, only you will go to the accessory muscles and learn them only after you learn these main muscles. Okay, first master the main muscles, then go to the accessory muscles. Yes. Next, abduction and adduction. This movement is abduction, this movement is adduction. Again, let us go to abduction first. Abduction meaning something, muscles over here should contract for this motion. Correct? Muscles over here should contract for this motion. When they contract, they'll pull the arm away. Correct? What muscles do we have over there? Number one, what muscle do we have? Where injections are given, IM injections are given? Deltoid. What other muscles we have? Supraspinatus. What other muscles we have? Serratus anterior. And the upper and lower fibers of trapezius as well. Trapezius is a very big muscle, right? Trapezius comes like this over here also. When it contracts, it pulls my arm. For abduction, what muscles are required? Main muscles, don't go to the accessory. Main muscles, what are required? Number one is major muscle is the deltoid muscle. I've already told you, if you don't know anything in shoulder joint, write off deltoid. You more or less you will be correct. Okay. So abduction, you will need deltoid, supraspinatus, serratus anterior, upper and lower fibers of trapezius. Simple, easy. Come to adduction. This movement was abduction. This movement is adduction. Again, apply the same logic. Something over here, okay, some muscles which are here should contract for this adduction movement to happen, isn't it? For adduction, what muscle should contract? If my arm is like this, to bring it back, what muscle should contract here? Pectoralis major, muscles of pectoral girdle, pectoralis major, and of course latissimus dorsi, short and long head, short head of biceps and long head of triceps. How do we remember this? Biceps is only 2, triceps is 3. So biceps is short, triceps is long. So short head of biceps, long head of triceps, along with pectoralis major muscle. Clear? Any doubt in this? Again, do not memorize. Sorry, do not mug up. Understand, apply the logic. Understand, apply the logic. Abduction, what are the muscles? Deltoid, supraspinatus, serratus anterior, upper and lower fibers of trapezius. Adduction, pectoralis major, long head of triceps, short head of biceps, and latissimus dorsi. Go to accessory muscles only if you understood this. If you haven't understood this only, you will get confused even more, right? Then let's go to medial and lateral rotation. This movement is lateral rotation. This movement is medial rotation. Lateral rotation, medial rotation. In medial rotation, again, we have pectoralis major. Same guys. See, this is medial rotation. Same logic. Same, again, I'm applying the same logic. Something should contract here to pull the arm towards us. That is what is medial rotation. Pectoralis major, anterior fibers of deltoid, latissimus dorsi, teres major. Whereas the lateral rotation, posterior fibers of deltoid, infraspinatus and teres minor. Infraspinatus and teres minor. As simple as it gets. Logic, apply logic, you will get the answer. Okay? Yes. Then, the combination of all these movements is what is called as circumduction. Combination of all these movements, all the muscles that I've spoken about until now, helps in circumduction. All right. Next, applied anatomy is perhaps the most important part of shoulder joint. Applied anatomy is perhaps the most important thing here. So first point that we should know is dislocation. So what is dislocation basically? Dislocation is whenever there is an injury to joint, the the articulating surfaces will be forced away from each other. That's it, right? This is a temporary injury, right? This is a temporary deformity where if you bring the articular surfaces back together, it corrects itself. Okay, it is just temporary. Then, shoulder is more prone for dislocation than others. I've already explained you why. Because of the disproportionate area of the articular surfaces and the laxity of the capsule. Of course, we have very strong strengthened capsules that strengthen the joint, but still, because of this disproportionate area of the articular surfaces, it becomes more prone. Okay. This occurs when the arm is abducted. Then, dislocation of glenohumeral joint. In the glenohumeral joint, why it happens? Extremely mobile and it provides wide movement at the expense of stability. I have already told you there is always a boon, there is always a bane. Correct? The boon is I get mobility. The bane is it becomes very unstable and it becomes prone for dislocations. Then, even though we have a very small bony glenoid cavity, but it is supplemented by the fibrous fibrocartilaginous glenoidal labrum, and of course we have certain ligamentous supports. Okay, of course we have certain ligamentous supports like I've already taught you before. Then the dislocation is divided into two: anterior dislocation and posterior dislocation. Anterior dislocation is more frequent, correct? It is more frequent and you come across if you are working in casualty in every single duty, in every single night duty, you will at least come across 2 to 3 shoulder dislocations. It's that common, especially if someone's a sports person or somebody is into rigorous sports and everything. It's very, very common, you know. So in any accident also, you will generally come patients, you know, patients will generally be holding onto their shoulder like this and they'll come. You know, the attitude is you look at 1 or 2 cases, you will not even need an x-ray, you will know it's an anterior dislocation. Okay, two types of dislocation: anterior and posterior. Anterior is more common, more frequent. Posterior is less common, right? Now it is usually associated with an isolated traumatic event. Clinically, all anterior dislocations are antero-inferior because antero-inferior is not as much strengthened as compared to other parts of the joint. Once the joint capsule in the cartilage is disrupted, then the joint is further. I have already told you, you know, the shoulder joint is susceptible to recurrent dislocations. Correct? When the dislocation occurs, let's say during how does it actually happen is during abduction, the head of the humerus presses against the lower unsupported part of the capsular ligament. Then almost always the dislocation is primarily subglenoid, and of course it can become, meaning what I'm trying to say is generally the dislocation happens like this. So if this is a glenoidal labrum and this is where the head of the humerus is, and this is how exactly the dislocation actually takes place, which is subglenoid. Imagine this is the glenoidal labrum, this is subglenoid. Of course, it can go this way also. It can go this way also. It can go up also. It can go this. Any direction, definitely it can go because the articular surface is so much. But generally, it is subglenoid. Why is it subglenoid? It is because the antero-inferior aspect of the shoulder joint is not as much strengthened as compared to other parts. Okay. Now, generally, the dislocation ends with the axillary nerve injured by direct compression of the humeral head on the nerve inferiorly as it passes through the quadrangular space. I've already answered one of your homework questions. Axillary nerve and the posterior circumflex humeral vessels, they come through the quadrangular space. I had taught this little trick. This is the upper triangular, quadrangular and lower triangular spaces. I had already taught about this in the previous sections. So, shoulder dislocation, two types, anterior and posterior. Anterior, it is almost always it is subglenoid. Why? Because the inferior aspect is not strengthened as much as the rest of the joint capsule. And when the dislocation happens, axillary nerve is more prone for injury. Axillary nerve is more prone for injury as compared to radial nerve. Now you know the answer for the clinical case scenario, why the option was radial nerve, because the radial nerve is not the most commonly injured nerve, rather it is the axillary nerve. Yes. Then occasionally the anterior-inferior dislocation is associated with fracture, which may require surgical reduction as well. Okay. Next, posterior dislocation is very rare. It is generally seen when somebody is throwing an somebody is throwing a seizure, or somebody has had an electrocution accident. Okay. Generally, when there is a rigorous muscular movement like this, which happens in seizures, somebody is throwing a fit, or when there is electrocution accident. So posterior is not so common. Clinical scenario, in the clinical scenario question, if they mention the patient is having continuous seizures, then it goes towards posterior dislocation. If they do not mention anything, if they just say shoulder dislocation, it is understood that it is anterior and it's not posterior, because anterior is that much common. Okay. Now let's just glance through elbow joint. I don't think it is as important as the shoulder joint. Okay. Now the human elbow is consists of basically three articulations: humero-ulnar joint, humero-radial joint, and radio-ulnar joint. What you should know is the type of the joint, correct? Humero-ulnar joint is a synovial hinge type of joint. Humeroradial joint is the capitulum of the humeral condyle and the concavity of the superior aspect of the head of the radius. I've already taught this. I've with so many diagrams in osteology. Just go back to the class. Radio-ulnar joint is a pivot type of synovial joint. Again, a question to you: types of joint. What is a pivot type? What is hinge? What is synovial? Types of joints is very important, along with all of these examples. Okay. Takeaway message: the elbow joint is a summation of three articulations. What are those? Humero-ulnar, humero-radial, radio-ulnar. Look at this beautiful diagram. Then, of course, here also we have a capsule. Anteriorly, it is attached above the humerus along the upper margins of the coronary and the radial fossa. Posteriorly, it is attached above the margins of the olecranon fossa of the humerus and the upper margin of the side of the olecranon process of ulna. Not very important. Nobody will ask you this. Next, synovial membrane and bursae of the elbow joint. Again, not so important for you. Nobody will ask. If you want to go through this, you can just, glance through this, but otherwise, not very important. Ligaments, again, you need to know a little bit of ligaments. Medially, the joint capsule thickens to form the medial or ulnar collateral ligament, which extends from the medial epicondyle of the humerus to the coronoid and the olecranon of the ulna. The ulnar collateral ligament is a triangular thickening of three main bands: anterior or cord-like band, posterior or fan-like band, and the oblique band. Okay. Laterally, the lateral or radial collateral ligament extends from the lateral, you can see here, lateral epicondyle of the humerus, and distally blends into the annular ligament of the radius. There's one more ligament, annular ligament of the radius, wraps around the head of the radius, attaches to the ulna anteriorly and posteriorly. Since we are talking about head of the radius, you will have to tell me the definitions of Galeazzi fracture and Montagia fracture, which is out of these two fractures, which involves the dislocation of head of the radius. Question number 1. Question number 2. Head of the radius is proximal or distal? These are the two questions related to this. You will tell me what is Galeazzi fracture and what is Montagia fracture. And had given a very nice mnemonic. Umesh was the mnemonic, if you remember, for Montagia fracture. What exactly happens in Montagia, you will tell me next class. Yes. Then next we have the radiocarpal joint, also known as wrist joint. Again, guys, wrist joint is radiocarpal. Ulnar bone has nothing to do with this joint. Ulnar definitely has got nothing to do with this wrist joint. Okay. Now it's a very complex joint. Why? Because you can clearly see how many bones do we have here. So many bones, so many articulating surfaces. Let's not complicate this, but the bones comprising the wrist includes the distal end of the radius and 8 carpal bones and the proximal portions of the 5 metacarpal bones. All of these bones participate in complex articulations that allow variable mobility of the hand. Okay? Yes. Then, what exactly is the wrist joint? Now, I told you already, ulna is not a part of the wrist joint. It only articulates with the radius just proximal to the wrist joint as the distal radio-ulnar joint. Ulna does not participate in the formation of the wrist joint by this fibrocartilaginous ligament called as articular disc. We actually have an articular disc here that prevents the ulna from forming the wrist joint along with rest of the bones here. Then together the carpal bones form the convex surface. You can clearly see how it is the convex surface which articulates with the concave surface of the radius. How beautiful is this, guys? I mean, look at how the beauty of the nature, right? Even though the scaphoid and lunate and all these bones are such small bones, but they are created by God with such precision. You can clearly see how all of these bones are fitting with each other so well, and they are forming this convex surface. And look at the beautiful convexity of the radius, how God has made this. You know, such a beautiful structure which is the human body, and to know about it and to learn about it is a real privilege. And we as doctors, and to be doctors, more than everything, guys, more than your exam, more than your viva, more than anything, just the complexity of the human body is something that should excite you. Just the complexity of how, just look at these small bones, how they are fitting into each other and how they are making a joint surface with the concave surface of the radius. Things like this, when you look at this, when you learn about these things, it should excite you. Exams are a part of our life. I agree. Exams are a very important part of our life. Without exams, you will not become doctors. But while you are studying for your examinations, you also enjoy these little things that you come across. That makes you feel like, wow, our human body is so complex and so beautiful. And I am given the chance to know about it. I am given the chance to learn about it and take it as a privilege. It makes you feel good also while you are studying, right? Study well for your exam, but enjoy these little joys. Yes. Now, look at the beautiful concave surface of the radius and the convex surface of all of these bones fitted together. And the wrist is an ellipsoid type of synovial joint. Then, capsule of the wrist joint, not so important, not as important as the shoulder joint. And there is a fibrous outer layer that attaches to the radius and ulna and the proximal row of the carpal bones. Okay. Then the ligaments of wrist joint, two important ligaments, palmar radiocarpal ligament and the ulnar collateral ligament, which runs from ulna to the triquetrum and pisiform bone. And of course, we have a radial collateral ligament. Three ligaments, palmar radiocarpal, radial collateral and ulnar collateral ligaments. Okay. Then the distal radio-ulnar joint is this joint that I'm talking about. This is the distal radio-ulnar joint. This is a pivot joint formed between the head of the ulna and ulnar notch and the lower end of the radius. The synovial membrane of this articulation is extremely loose and it extends upwards as a recess between the radius and ulna. This is the membrane that I'm talking about. The movement of pronation and supination of the forearm involve a rotatory movement around the vertical axis at the proximal and distal radio-ulnar joints. Of course, we have ligaments here also, anterior radio-ulnar and posterior radio-ulnar ligaments, which will strengthen the distal radio-ulnar joint. Look at this, how the movement of radius and ulna takes place. Look at this, how beautifully the bones are moving in posteriorly and anteriorly when I'm doing this pronation and supination movement along the vertical axis. Yes. Now this is a small table that I have chosen. This will help you, number one, to quickly revise it. Number two, to know the ligaments, blood supply, movement, and everything is there. All the joints, just before going to the exam, even if you don't have time to study the entire joints, right? Just go through these table. It's a beautiful table that consists of all the joints of upper limb. Just go through this table. The very important one, of course, is the shoulder joint. And other joints are also important, but go through the the shoulder joint, and here the most important table or the most important column is the type of the joint. Okay, type of the joint over here is the most important, because this is where the questions come from. This is where the questions are asked in your viva. Okay, type of the joints and examples are here. All right, so that ends our class, and the highlight of the class was shoulder joint. What do you write for shoulder joint? Opening statement. What is the shoulder joint? The type of the joint. Number 2, articulating surfaces. Number 3, relations. Number 4, ligaments. Number 5, applied anatomy. Sorry, number 5 is the movements and the muscles which are responsible for the movement. Number 6 is the applied anatomy, in which you will talk about the movements. Okay, so that ends up that ends the today's class, and you can, if you have any doubts, you can always reach out to us across all the social media handles. And let's take some poll questions. Okay, let me stop sharing the screen and I'll take the poll questions now. Interesting poll questions. Okay, looks like we don't have poll questions today. That's all right. We have already done a clinical case scenario. I think will be very useful to us. And of course, you can follow us across all the social media handles. And if you have any doubt, you can get back to us. And thank you so much, guys. I wish you all the very best, and go through the shoulder joint, a very important topic. And good night. All the very best. Thank you.